So let's just get started. Good morning, everybody. Almost good afternoon. Thanks to Dr. Leader. He gets the award for traveling the furthest. I live about 6 miles away. So as Cindy and the rest of the team are wondering where the heck is Dr. Fischer, I was in my kitchen having coffee at 10 o'clock when we started and got to roll over here pretty easily. So thank you, Dr. Leader, for coming all the way from Tufts. And you really have a unique niche. And I'm sure you're really, sought out quite often. We struggle with the dental aspects, and for my patients who know me, they realize that I don't ever talk about the dental aspects. So just one more thing to do. Thank you. Just wanted to thank the foundation and the organizers of this event. This is the 5th year we're doing this. And if you look back at the agendas over the 5 years, I think we've gone through things like stem cell transplant, interstitial lung disease, gastrointestinal manifestations, occupational therapy, physical therapy. Today we have a wellness coach, talking about joyful living and mental health aspects from an integrative health perspective and from a dedicated psychological perspective. And as a person who's a rheumatologist taking care of scleroderma, it's very overwhelming to try to address all these topics. So I can only imagine how you all feel and how many topics need to be covered and how sometimes your questions are so much better than our answers. So with that, I will say this is not a formal presentation as much as it is an opportunity to kind of break this down into questions and answers. And I'll again put the disclaimer, I think your questions are going to be better than my answers. Some rules: there are no bad questions, okay? How many people here went to medical school? Dental school? Okay. How many people here did a fellowship in rheumatology? How many people here have tremendous expertise in other areas that they work in, right? So that's for everybody to raise your hand. So you all have expertise that for those of us who take care of scleroderma, we don't have. So again, I would say if someone were to ask me, what do I not know about how a computer works, or what do I not know about how a car works, or what do I not know about finances, or anything other than this, I have a lot of very basic questions. And so I would say, let's all put aside any questions about whether we should be embarrassed, because there isn't an embarrassing question, there isn't a bad question, there isn't a dumb question. We can go very basic, we can go very advanced. So with that disclaimer, I'm here to try to answer any questions you may have. Yeah, please.
I have a couple about transplants. If you have interstitial lung disease and your lungs just give out, which I don't know if that's something that could happen or not, are lung transplants ever used for that kind of disease? And if you had a lung transplant, would the disease affect the new lung?
Okay, so the question's about lung transplant in particular or transplants in general?
Well, that particular.
Yeah, so we recommend primarily in scleroderma 2 types of transplants. So I'll answer it in general first. One is a kidney transplant. A kidney transplant would be indicated in a patient who has developed scleroderma renal crisis, where the kidneys get involved. And after a couple of years, if they haven't responded and the patient has been on dialysis, typically we wait 2 years. It is a little bit of a magic number, 2 years, because there have been data to support the notion that patients can recover as far out as 2 years. So we tend to put in a 2-year kind of calendar event because we would not want to transplant kidneys. That's okay. Anybody who has a ringer, if you're going to have it on, we'd like kind of some hot, like pop tunes, something from the 60s, something to kind of spark up the room a little bit, spark it up, liven the conversation. But that's okay. We all live in a modern technology, so no worries at all. If mine goes off, I apologize. So we'll recommend kidney transplant 2 years post-renal crisis injury if the patient's on dialysis and we don't think there's any real hope for recovery of their kidney function. In those scenarios, kidney transplants are as successful in scleroderma as they are in anybody else. Okay, so the most common cause of need for a kidney transplant is not scleroderma. It's things like diabetes, among other illnesses. And so if you look at studies that have compared how a scleroderma patient does with a kidney transplant compared to the other groups, just as fine. The harder group to transplant, the other topic, is lung transplant. And we would recommend lung transplant in two types of patients. Pulmonary hypertensive patients, patients who have respiratory failure because of that complication of having advanced pulmonary hypertension, and in patients who have advanced lung fibrosis, advanced interstitial lung disease. The treatments for pulmonary hypertension have gotten really, really good, very, very effective. There are 13 plus FDA-approved options now for the treatment of pulmonary hypertension. People are recognizing it earlier and earlier, diagnosing it earlier and earlier, treating it earlier and earlier. So it's very, very uncommon to now need a lung transplant from pulmonary hypertension just because the treatments medically are so much better than they ever were. The other patient, pulmonary fibrosis, which can be progressive in a minority of scleroderma patients, but is certainly a major concern, for which we don't have such great treatment. That group of patients often needs a lung transplant, more so than the pulmonary hypertensive patient. We don't like to pursue a lung transplant kind of quickly, right? It's we want to have patients go through the usual channels first. There are major obstacles to lung transplantation in scleroderma, and they have to do, believe it or not, with the esophagus. A transplanted patient needs to have a very effective esophagus. They need to not aspirate, ingest contents of saliva, other liquid, down the wrong pipe, so to speak, going from what we want it to go, where we want it to go to the food pipe. Sometimes it spills over into the trachea, the windpipe, and by getting into the airways, it can damage transplanted lungs. So it's a huge obstacle. It is center dependent. Some centers, like the University of Colorado, really does not like to pursue lung transplantation because they've had experiences that have not played out well because the post-transplant period doesn't go well because of esophageal abnormalities. Some centers like UCSF and Duke and Pittsburgh are much more aggressive, shall we say, and will transplant a scleroderma patient. If you look at the data, it's small series, but carefully selected patients, meaning transplanted patients who went through the esophageal care, who had those issues addressed, do just as well as other transplanted patients, which means that a patient who has advanced lung disease from scleroderma can be transplanted if we can address the esophageal issues. Does the organ get attacked by the disease? We don't see that. We don't see that. So my role in this would be if I have a patient who has, progressed beyond medical therapy. I'm worried that I have not as much to offer them medically as I could if I could transplant them. We would recommend a transplant evaluation. We're not the ones who ultimately make that decision. The transplant teams are the ones that make that decision. We're struggling a little bit here because of local resources and the university, which we would like to keep our patients in state if they needed a lung transplant. But I know that the surgeons here and the team here are not eager for scleroderma esophageal concerns. If every answer is that long, we're going to be in trouble. So I'll try to shorten it. I'm sorry. Okay. Other questions?
I have another transplant.
I'm going to skip to somebody else for a second, but we'll absolutely come back to you. Yes?
Doc, we had seen you a couple months ago, and we had this conversation about some drugs that we possibly could get from Europe.
Drugs from Europe.
Yeah.
Is this being recorded? I don't like the way this is starting. Yeah, go ahead.
Pharmaceutical drugs.
I know. Just
But actually, we learned this from a lady in our Colorado Springs
yeah.
group, and she's here. But
You're talking Gaviscon?
Right.
Sure.
It was the Gav.
Yeah.
And so, is there a big gap between what's happening in the States Because we've also been on a study that was linked to some of the stuff that came from around the world.
Sure.
And the time frame for that to happen and then for us to get on the receiving end.
Yeah, I mean, so regulatory approval is by country, right? And, you know, we're very quick to report in the newspaper how drugs get approved and then there are bad outcomes. And it's a real balance, right? We don't want drugs on the market that are not safe, right? And the United States has its regulatory, you know, the best example for scleroderma is domperidone, Motilium. You all heard of that? It's a drug that we use for motility. And it's not approved in the United States because there have been reports of sudden death associated with this drug. And that's true. It is a risk. And when the Food and Drug Administration looks at, you know, all the products, they look at, you know, risk benefits. One of the best drugs taken off the market for rheumatologists was Vioxx. Rheumatologists love that drug, but it has some safety concerns. So we can't write for it anymore. And that's okay. I'm okay practicing in that environment. I would say that I like working in a country that takes its regulatory approval very, very seriously. But it does mean that there are some drugs that we would kind of like access to and would like to be able to talk to our patients on an individual level to be able to talk about the pros and cons, and maybe this drug makes sense for that person. I don't know enough about Gaviscon and that treatment for reflux disease, but it is a treatment for reflux that at one of the gastroenterologists I work with, Dr. Menard Katcher, was talking to me about, and he was interested in kind of looking at that drug. And domperidone, Motilium, is another example where we don't have good treatment for motility. The most commonly used treatment for motility to help move food down is Reglan, metoclopramide, which has a horrible side effect profile for some patients. And so we're not that eager about that drug. How did it get approved? I don't know. I'm happy that it's approved, but it has to be used on an individualized basis. Motilium, domperidone, we use that all the time. And yes, there is this heart arrhythmia risk, and so we have to watch the EKG in our patients on Motilium. Probably twice a year they get an EKG, once a year, to look at certain intervals on the electrocardiogram to make sure it's safe. I think that if we can kind of have individualized discussions with our patients, you know, there are ways to get around some of this, but I can understand why it's frustrating also. Everyone pays healthcare dollars and insurance. Why do I have to order it offshore? One thing I would say is that I would like to make it feel less uncomfortable in the sense of you're not doing anything wrong, this is not an illegal trade. I mean, this is basically, we realize you all have a very difficult to treat disease without good studies, and if we can find something that can help you, and if we can do it in a way that we think can be done safely, we should do that in a partnership. We'd like to not have, we'd like to be a part of that decision. Right? So if I have a patient who wants to go on domperidone, Motilium, I think it's better that we talk about it, and then I can know that I can try to monitor for its safety rather than saying, well, I can't get it through the government anyway, my insurance won't pay for it, I'm just going to order it offline. You know, I'm just going to you know, leave it out of the clinic. I think we're better off having that conversation together. Yes?
You accepting patients?
Yeah.
Seriously, my wife is.
Yeah, and you know, I mean, and Cindy and the others at the Scleroderma Foundation realize that there are providers in this region who see, you know, a lot of scleroderma patients, and I'm one of them. And yes, that would be something that you could follow up with me afterwards. Sometimes, you know, choice of doctors is about relationships and who your primary wants to work with and where you live and what your insurance will cover. I'm one of the docs in town that does see a lot of scleroderma, so is my partner. There are other excellent doctors who can see patients with scleroderma, but yes, happy to. Yeah.
Two questions about medication. First of all, relative to interstitial lung disease, if someone has had a bad reaction to CellCept where there's not much alternative available, should it not be tried again, or is there a possibility that over a period of time later, with a different drug regimen going on in their body, that CellCept ought to be reconsidered?
Okay. So the question about treating interstitial lung disease and a particular allergic reaction to a medication, in this case it's CellCept, and or reaction and or intolerance to, should we try it again? So the idea of re-challenging drug, I think, is kind of the broader question. Can you re-challenge drug? And the answer is yes, and it just depends, though, on what the reaction was, right? So a patient who had anaphylactic shock, right? Their airway gets constricted, their tongue gets swollen, it's a life-threatening emergency, they need epinephrine, we're not going to re-challenge that patient. Patient who has a horrible rash, like a sulfa-related rash, we tend to not challenge that patient because that could be another sign of worrisome consequences on the spectrum of heading towards anaphylaxis. But that being said, if this will take it with a grain of salt, nuisance side effects, adverse effects, which could include gastrointestinal problems, which could include bizarre symptoms. I don't know, I just didn't feel good on the drug. I was, lightheaded, I got headaches. Any host of those kinds of things, yeah, sometimes we will re-challenge that patient, particularly if we think that the drug that we want to use is so much far superior than the others that you weigh those risks and benefits. Now, for CellCept in interstitial lung disease, it's not that clear how effective this drug is. It is probably one of our better 2 or 3 drugs, but it's not like this is the only drug that works, so we have to put our patient through a potential risky re-challenge. For those of us who are more stubborn than others, as providers, we like that drug, yeah, absolutely, we will re-challenge those patients. And I think you have to do so with full disclosure. Hey, you got sick the first time, I'm giving it to you again, you may get sick and or sicker the second time. Yes?
What about Dexilent?
Dexilent. So Dexilent is an anti-acid medication that falls in the same category as all the other proton pump inhibitors. Those are medications that suppress acid production in the stomach.
Does it work as well as Nexium?
I don't think we really have good head-to-head data, right? Those are tough to do because that means one pharmaceutical company has to challenge another pharmaceutical company, which means one of the companies loses, typically. So you're left with trial and error, and truthfully, I tend to tell my patients that those proton pump inhibitors are a lot like ice cream flavors, right? I like strawberry, but this person likes chocolate, and this person likes, whatever. And the reality is that some patients do better on Nexium, Prilosec, Prevacid. Some insurance companies want you to do better on Nexium or Prilosec. And I don't know, Dexilent, the convenience for me for Dexilent, it's a once a day. Sometimes for some of the other patients who have bad reflux disease, they need a twice a day at a higher dose, and Dexilent is sort of a once a day. But insurance carriers, providers, cost, all that goes into it. So what I try to tell my patients is start on this one, but here's a list of 5 others, and if your insurance says they'll like the other 5, I'm okay going with any of the other 5.
Well, I'm on Nexium, 80 milligrams a day.
Right, which is a high dose.
It is a high dose.
Yes.
But now I have a golf ball filling right here. And
Right.
It's really...
So those kinds of symptoms where we're having trouble swallowing, where it feels like something is stuck, is always a good time to call your gastroenterologist because you may need another dilation. The esophagus needs to get dilated in some of our scleroderma patients because of the severity of the reflux disease. And when the reflux disease is very severe, it can cause some inflammation and narrowing of the esophageal lumen, the actual size of the pipe.
Do you have to worry about it exploding or something?
No,
Or
no, I've no,
bleeding to
right,
death?
right. So no, so again, this is if I was to do the procedure, then you might have to worry about those things. But if you had a dedicated provider who knows how to do an upper endoscopy, and I think who is not uncomfortable with a scleroderma patient, right? And a lot, and there can be many providers who are uncomfortable with a scleroderma patient, but getting dilated is something that often can help a patient really feel better, swallow more effectively. And it does need to be, I'll ask, who here has had their esophagus dilated? Okay, so handful on this side, a few over here. It is something that we do. It's something that we recommend. It's also important that we don't jump to conclusions. because there are other things to think about if someone says that they feel like they have a golf ball stuck in there. And it's not always just a dilation that's needed, but having visual inspection of the esophagus would be important, okay? And not just changing. Sometimes, if it's very convincing that this is a sign of bad reflux, it would be reasonable to say, let's adjust your reflux regimen. Let's be more aggressive, so to speak. 80 of Nexium already is aggressive, but let's say we have a patient who's not on reflux care and has that symptom. It would be reasonable to say, let's put you on reflux care. Let's bring you back in a month, see how that symptom is, and then think about getting an upper endoscopy. But this highlights, I think that question in particular highlights, and with Dr. Leader before me, this has to be a team approach. Because I would say as a scleroderma doc, I can't take care of scleroderma without good GI help. I think now I've also learned I can't take care of scleroderma without good dental help, okay? And there has to be that partnership as well. But this is very fundamental because, you know, just like the question before, who has Raynauds, and all the hands went up. Who has reflux disease? Well, if your hand isn't up, I would raise it for you, because if you have scleroderma, even if you don't have heartburn, you do have reflux disease. So if you're a scleroderma patient and you don't have a gastroenterologist yet, ask your scleroderma doc at your next appointment to please get you one, or your primary care doctor to get you one, because you can't take care of this disease without that help. Other questions? Yes?
Do you have any proactive exercises or anything a person can do to prevent pulmonary hypertension from increasing?
Yeah, so the question is, do we have exercises or other things that we can do to help prevent pulmonary hypertension from increasing? So I would say yes, probably dedicated exercise, dedicated cardiopulmonary exercise, which is truly a strict and rigid program of rehabilitation, meaning oftentimes in a physical therapy or respiratory therapy suite with a treadmill, with a coach, with an oxygen monitor, and with real dedicated goals of how far we want our patients to walk, at what speed, and ensuring their oxygen's okay. There isn't a diet, there isn't a drink, there isn't a feel-good attitude, there isn't anything that we can do to prevent pulmonary hypertension from getting worse. We have great treatment, better treatment now than ever before for pulmonary hypertension management. And the one exercise that has been shown to help outcomes in pulmonary hypertension, and in some ways almost as effective as some of the medications, is that cardiopulmonary rehab. Yes?
Water aerobics in a pool does the same thing though, correct? Like in a walking pool?
I like the idea of water aerobics in a pool. I'm not aware of a study that has looked at pulmonary hypertension outcome measures in a formalized study. So my answer was more geared towards a German study that looked at an outcome in pulmonary hypertension, and pulmonary rehab impacted favorably on that outcome. Water aerobics, I think, are a great way to exercise for arthritis patients, maybe a great way to exercise for scleroderma patients. There can be challenges with getting in the water in patients who have oxygen requirements, so that's a challenge, but I like the idea of water aerobics. I can't say with the same degree of confidence that water aerobics have the same degree of benefits as cardiopulmonary rehab, but I like water aerobics. Yes, Bobby?
Like for numbness and tingling, the side effects of the fingers and the toes, how severe or not severe can
How severe?
What can you do to help it?
Yeah, so the question is numbness, tingling, fingers and toes. So not a real scleroderma specific problem, but I recognize that that can happen, of course, in scleroderma for a couple of reasons. Number one, patients can get in the early phases of their disease. Some people show up actually with carpal tunnel. That's how they showed up to their initial appointment to see a rheumatologist or their primary care doc. Swelling of the hands, stiffness of the hands, pressing on the nerves, carpal tunnel. It's not uncommon to have carpal tunnel at first and need carpal tunnel surgery, which we don't like to do, but that's something that happens before the diagnosis is made. Not so much in the feet. We don't hear about that so much in the feet. So the initial manifestation of scleroderma could be with carpal tunnel, and the rule is try to address the underlying cause and address the inflammation that's leading to that carpal tunnel, that pressure on the nerves. I think you're asking a different question, which maybe relates to the downstream effects, and sometimes we don't have a good answer as to why someone's having numbness, tingling in their hands or feet. And that's associated with many other diseases. Diabetes is a good example. There are neurologic diseases. I don't think it's really a common medication side effect. There's not really much specific about scleroderma that leads to that, but I get that we see some of our patients who have it. Truthfully, our first rule of thumb is to make sure we're not missing another disease, something else that's causing it. And then our second rule of thumb, if nobody has any great ideas as to why that has come about, is to try to manage the symptom. And that's where you come up with some medications like Neurontin or gabapentin or Lyrica, which are not scleroderma specific, but they are for peripheral neuropathy. And they have a host of side effects, and it depends on how much it's impacting the patient. Sometimes it's very troubling, and so we'll go ahead with those treatments, and sometimes it's more, you know what, I'm already on 12 medications, I don't want to be on 13. Yes?
Speaking of that, I get a little overwhelmed by the side effects of all the medicines. I mean, you read that sheet and you're just like,
Yeah.
what? But then
Right.
you don't really see them in yourself. So, like, if you don't see something in the first year of taking something like Reglan, for example, does that mean you won't see it in the future, or do they compound? Like, you could go 10 years and then really see a bad side effect.
Yeah, product inserts are a real problem, aren't
Yeah.
they? Yeah, we're trying to abolish them, but so far we haven't made a lot of progress. And I think they're abolished in Europe, just to get that. Side effects. So here's what I would say. We really don't do a good job of thinking about side effects for our patients. And also because everything has side effects. So you want them to take the drug because of the benefits, but so that's tricky. Plus, you start adding medications. Oh my gosh, so I got 7 different medications. What are the interactions? I don't know. I try to ask my patients to get a pharmacist. I like it when my patients have a specific pharmacist that they go to, or a pharmacist they go to. Not because just of the social reality, it's nice to get to know your pharmacist, I guess, but it's really nice when you have a dedicated expert. And physicians are not that when it comes to pharmacology. When should I take this and this and this? I don't know. I don't always know. So I like having my patients know that they can talk to a pharmacist about the best time and perhaps raise concerns about potential interactions to bring back to me. That's number one. But to answer more specifically, if it has a side effect, and Reglan, its most notorious problem is that it can lead to what we call Parkinsonian type side effects, where they get what we call, we like to confuse patients so we come up with really crazy words, extrapyramidal symptoms, whereby it's tremor, it's Parkinsonian-like. And that's a common, so to speak, side effect on Reglan. I don't know how common, but it's something that we're not surprised in seeing. And I would say that doesn't go away just because the patient's been on it for 6 months and didn't see it. That's sort of a lifelong. We would worry about that throughout the course of a patient being on a drug. Just like we'll pick on CellCept. CellCept can cause lots of gastrointestinal side effects. Just because a patient's been on CellCept for 3 years and hasn't had those doesn't mean in year 4 they can't get them. So we have to always think about side effects in our patients who have new problems. Dry mouth was the classic. I don't know of a medication that doesn't cause dry mouth. So that's another common side effect that we see. And we have to think about that all the time. And then, how do you balance the product insert? Well, I like that we practice in an era whereby there is full disclosure, that there is transparency. But I do think there's a cost benefit, a risk benefit, a pro and con conversation, right? Because that's ultimately what we have to do. We have to balance what we think is going to be beneficial against what we think could be detrimental. Yes?
Since you're talking about side effects, is there a Raynauds oral medication that does not cause your blood pressure to drop?
Yes. So are there Raynauds Phenomenon associated medications that do not cause the blood pressure to drop? Yes. So the management of Raynauds Phenomenon has much to be desired, right? We have lots of limitations there. Our general approach is the first thing to do is to organize a conference in a nice, warm, moist room like we did here. This is perfect. Okay, perfect, because I think in years past it was colder. So the typical approach to Raynauds Phenomenon first, in terms of management, is what can you do without medications, right? Dressing warm, maybe a blood thinner like a baby aspirin. Some people like a supplement, niacin. again, just sort of because of heat packs, that kind of stuff. If you're going to go to the pharmacologic management for Raynauds phenomenon, we typically start with a group of medications that do lower the blood pressure, the calcium channel blockers. And they're more effective than others, but they do have that side effect. But there are other medications that we use. Probably the most commonly used outside of the calcium channel blocker is pentoxyphylline, Trentol. And that face was, how come you never mentioned that to me in clinic before, probably? So I'm sorry. That's why we have these patient education days, so I can provide better care for my patients. Trentol, pentoxyphylline is one of them. It's a 3 times a day drug. Dr. Collier, well known, my predecessor at the university, was a big, I don't want to say he was a pusher, but he was a pentoxyphylline prescriber. And a lot of his patients that I inherited, I noted are on it. And they've told me, plus minus, it can help. It does not lower the blood pressure. That's one. Some people find benefit from Coumadin, the blood thinner. Warfarin is the other name for it. It's a little bit more of a complicated drug. It needs lots of monitoring, bleeding risk. Haven't been overwhelmed with that drug, so I'm not a big user of that one. The best treatments for Raynauds phenomenon are the pulmonary hypertension treatments. The treatments that are approved by the Food and Drug Administration for the life-threatening lung disease and pulmonary hypertension are very effective in some cases for Raynauds phenomenon. The challenge there is kind of a mixed bag because there's the good reality of not having pulmonary hypertension and so not needing the drug for that. The downside is the insurance companies won't approve it for Raynauds phenomenon. In Europe, they are. In the United States, they aren't. And so getting medications like sildenafil, which is Revatio, same drug as Viagra. Tadalafil, which is Cialis, also called Adcirca. So the drugs that have been used for erectile dysfunction are effective for pulmonary hypertension and are effective for Raynauds phenomenon. And some of the drugs like Tracleer, Macitensin, ambrisentan, which are other class of pulmonary hypertension therapies, are probably effective for digital ulcers and for Raynauds phenomenon, but very hard to get. Yes?
You have shared, I missed it maybe, but when should you consider going the prescription route to place, what severity or what symptoms?
For Raynauds phenomenon. So the question is, at what point do we go the pharmacologic route for Raynauds phenomenon? So those who are under my care know that I run a semi-democracy, right? So this is an area within which I am relatively democratic in nature. There are other things that are much more totalitarian and autocratic in nature, but this is one where I look to my patients and I ask them, how much does it bother them? If the Raynauds phenomenon bothers the patient enough to want a medication, that's usually enough for me. Sometimes, though, it's very obvious because there are sores on the tips of the fingers or there are scenarios whereby the lack of blood supply, because that's what this is lack of blood supply, is dangerous enough to potentially threaten a digit, threaten a finger. And in those cases, it's, I would say, very much indicated it's a no-brainer. But the pharmacologic management of Raynauds phenomenon, because it is universal in scleroderma, okay, it really is. All of our scleroderma patients get Raynauds phenomenon. So then the question is, do you need to treat it? Well, no, only if it's giving the patient enough trouble to warrant therapy. The contrast, and where I say I'm not so democratic, is something like reflux disease, just because it was brought up. It's not about heartburn. In that scenario, gastroesophageal reflux disease can have devastating consequences. And so even without symptoms, we will want to manage it. And we heard about some of them, the oral ones. But I'm talking about esophageal cancer and all the kinds of problems. Yes, other questions? Yes, right here, right in front of me.
Yeah,
Sorry.
I read that lupus can be brought on by drugs and can be temporary. Can the same thing happen with scleroderma?
So the question is, so lupus can be brought on by drugs, by medications, and can be temporary. Can the same thing happen for scleroderma? So you're absolutely right in that there are medications that can cause a lupus-like illness, or candidly, frankly, cause lupus. That is not the case for scleroderma. We don't have any specific medications that lead to a transient scleroderma-like illness that if you pull the drug away, it goes away. That being said, there are some exposures that are worth asking about, just from the standpoint of this may have led to
I
scleroderma.
had a reaction to some drugs and then my scleroderma numbers were up, so I didn't
Uh-huh.
know.
Scleroderma numbers were up. Okay, I'm not exactly sure of your situation particularly. There are lots of environmental and/or effects that could lead to a flare. I don't know of a drug to linking to scleroderma per se. There are certain exposures that, whether it's chemical spills, that can lead to scleroderma-like illnesses. Not truly the scleroderma that we see, though, in its full form. Sure. Any other questions? Yes, ma'am.
Is this condition inherited?
There is a growing appreciation that there are genetic associations with this disease. And for all patients with scleroderma, you should know about the ability to contribute to our knowledge, not answer questions about your own genetic background, but contribute to the knowledge of the genetics of scleroderma by reaching out to Maureen Mays, M-A-Y-E-S. If you don't have that, you can certainly get it from the Scleroderma Foundation, folks here and or the website. She is a genetic sort of expert in scleroderma down in Houston. And you can send your blood and participate in her study by filling out questionnaires and giving her a blood sample. So we're learning more and more about the genetics of this disease. There are certain populations that do have an increased exposure and risk. I shouldn't say exposure, an increased risk. And they are some specific Native American tribes. But the reality is that we see this disease more in women than in men. Typically, ages 30 to 60 are more common ages, but we do see it in some teenagers and some folks older than 60. And we see it from around the world in all ethnicities. I could think of one patient whose mom also has the disease. I see both of them. I cannot think of any other patient that I see that tells me that my sister, my brother, my mother, my father had the disease. So it's not a clear genetic link. Yes?
My daughter just got diagnosed with Raynauds.
Okay.
So,
Okay. Raynauds is pretty common. About 10% of women have Raynauds phenomenon. Anybody who has Raynauds phenomenon should bring it up to their primary care doctor. I would say your daughter gets a little asterisk by her just because her mom has scleroderma. And I say that obviously because I know you from the clinic. But I'm just saying that it doesn't mean that the two are linked. But sure, should be evaluated. There are other autoimmune diseases that travel together, right? So we see patients whose daughter has lupus, they have scleroderma. Sister with multiple sclerosis, aunt with Crohn's, kid with psoriasis. We see that. I'm not sure that we have good answers otherwise. Yes?
So, pushing the limits on your admonition that there is no bad question. And I'd also be interested in hearing from anyone else here. I'm wondering about, for pain management, any cannabis-type products, particularly edibles. You wouldn't want to damage the lungs.
Sure.
But is there, something that doesn't contribute to a high feeling? But has anyone had experience with some sort of a product for pain
Sure.
management?
So I'm asked that question, in scleroderma, not even in scleroderma. I mean, so rheumatologists, just as a straight up, we're not really trained in pain management. So that's definitely one of our, where we sometimes don't necessarily meet what patients expect from us in terms of, well, it says arthritis on your door, why aren't you doing that, Pain management is something that we sometimes fall short. And we often like to partner with pain management experts. And those typically are anesthesiologists who will do various pain injection blocks. Sometimes they are physical medicine doctors, PMNR, physical medicine and rehab, that focus on different mechanical modalities of how to help patients with different rehab techniques. So, and some are prescribing opioids, okay? We don't often do as good of a job as we should. So some of my patients do need to see pain management specialists. I am asked the question about what's the role of marijuana in managing my disease? And I would say there isn't a role for marijuana and managing your disease in any evidence-based format. Some patients will tell me, well, when I try this or when I have this, I feel better. Well, I like that. That's good to hear. And if it can be done in a safe way, I'm okay with it. Just like someone may say to me, well, if I have a glass of wine and have a massage or spend some time talking to my best friend in a coffee shop, that also helps me feel better. I'm okay with that too. I think it's all about moderation and all about being careful. I would much prefer that I'm aware of what is being done than kind of feeling like it has to be hidden and hushed and brushed under the carpet. If someone wanted to use medicinal marijuana or non-medicinal marijuana because it helped them feel better, I would just say, well, let's figure out the best way to deliver that so it could be done safely, right? And so that may be where I would avoid inhaled products. I have a lot of my patients who find that marijuana gives them some relief. I'm okay with that. Are you telling me time, or are we okay? Okay.
I've heard that scleroderma actually kind of slows the circulation system, so wouldn't that be counterproductive?
Yeah, you're not looking at good evidence-based study, and that's hard, right? So, but I think, so Cindy's mentioning that you've heard it can slow the circulation. I haven't encountered that. I would say the things that I'm not comfortable with, right? So cocaine, methamphetamine, I don't care how good you feel with them, that's not going to be okay. And it's not okay for a lot of reasons, but it's not okay also because you're talking about circulation. That's devastating, right? So a glass of wine, I'm okay with. As far as I know, that's still legal. We live in a state where marijuana is legal, and so I'm comfortable saying that if that, we can add heroin to that no list also, okay? But I think that knowing that we want to be, again, forthright, and again, I mean, this is as humbling of a disease. When I say there are no bad questions, it's because I'm sitting up here. We're making it up in clinic. You all know that. We're making it up. We're trying to do the best that we can, but we're making it up. And if we can do that, and at least right, the lights are on. I'm not going to be selling you something, right? I am sharing with you what we know, what we don't know. If medicinal marijuana provides a patient with some relief of their symptoms, I think we're okay. Let's just have that conversation. 2 minutes. What happens in 2 minutes? Right, what was that? The Muppets, the guy on the drums, animal, he just kind of exploded? Yeah.
How important is a skin score when you're
skin score.
When you're evaluating a scleroderma patient?
Right, so skin scores are, okay, so what is a skin score? A skin score is a research tool, predominantly, to be able to compare outcomes of a treatment. Okay, so if I'm a scleroderma doctor in Aurora, Colorado, and I want to participate in a research study, and there are doctors in New Zealand, South America, the Middle East, the UK, and we want to know if our treatment is working, we have to have some objective measure of an outcome. One of those an objective outcome measure means that it's not the doctor or the patient saying how they are doing. That's not objective, that's subjective. Objective means I have a number, a blood test, a CAT scan score, a breathing test, a skin score. Okay? Now, there is a uniform skin scoring system, and it's named after a pioneer in scleroderma from South Carolina, Dr. Jerry Rodman, R-O-D-N-A-N. And we all use the modified Rodman skin score as an outcome measure in clinical trials. It is helpful clinically if you're going to share patients across providers, if you're going to look back over time or look, and try to figure out where your patient came from and how they're doing. It's helpful to have records of what their skin score was. So if I see somebody new, I will often do a skin score and then not repeat it, maybe for a year, maybe 6 months, maybe for 2 years, maybe 10 years down the road, you look at it. Practically speaking, we know when our patients have a lot of skin thickening, we know when they don't have a lot of skin thickening. So when they have not much skin thickening, a modified Rodman skin score is not helpful for me. I know they have skin's not their problem. If they have a lot of skin thickening and that's what's driving treatment, I may choose to do that skin score more often. I met a patient for the first time last week who saw one of my former partners at National Jewish, and she was traveling from out of state, and he had commented on his skin score from March, And my skin score from this week was very different from his. It was much better. So candidly, I'm happy that it's better, but I don't know if it's real because it's not an exact science. It's not precise. It's me feeling the skin and giving it a score at 17 sites. How do I know that his score is my score? I don't. And we know that there's tremendous inter-investigator variability. I like a skin score in my diffuse patients where skin is a problem so I can help measure disease outcome. And it's just a form. One more question. That's like pressure. Yeah, very good.
Have there been studies done in locations where there are high amounts of scleroderma patients have developed because of, well, who knows what, but are there any studies done about that?
You're asking from an epidemiology perspective, meaning is there an exposure here that's concerning? We're getting all of this increased signal?
More people ended up with scleroderma that perhaps grew up in this area back in the 50s.
Right.
Those kinds of issues.
Yeah, so, yes, there are studies looking at clusters of patients. They've been more genetic, and I think the most clear one has been a Native American, tribal related relationship. Not so much exposures. There were a couple of environmental insults. There was, and or oils that got into the commercial market, a rapeseed oil that got, I believe it was in Italy or Spain, a toxic oil. So there have been a few outbreaks that way for scleroderma-like conditions, but I'm not aware of if you grew up in this part of the country at this era with this type of exposure, your risk is 100-fold. I don't think we have that confidence. Other questions? I'm done, I better not ask that. Thank you all for coming. Yeah, I'm just gonna monopolize the microphone for one more moment, which is to say, so first of all, a lot of my patients, are here, I know that, so it's good to see you all. And the other thing I would say is that it's good to see you if you're not my patient also. But this day, I think has really evolved. And again, I mentioned the variety of topics. This is clearly your day, and clearly the Scleroderma Foundation's day, because I would not have been creative enough to put this type of agenda together. And so I would just say, as you all are thinking about the day and how it's going and what you wanted to see differently, please know that that's what happens, right? So your feedback and your creativity generates next year's agenda. So thank you.